Hi and welcome to a new episode of your weekly medical TV show on الكرمة TV, White Coat. Congenital heart defects are the most common types of birth defects. And babies born with these conditions are living longer, healthier lives now after all the development and advancement of medical care for those patients. Congenital heart defects affects nearly about 1% of birth year in the United States. 25% of those babies with congenital heart defects have critical congenital heart defects. Infants with critical congenital heart disease generally needed surgery or other procedure in their first year of life. Congenital heart disease are the leading cause of birth defect-associated infant illness and death in the United States of America. Survival of infants with congenital heart disease depend on how severe the defect is, when it's diagnosed, and how it's treated. At least 15% of congenital heart defects are associated with genetic condition, and in the United States of America, the hospital cost for the population with individuals of cardiovascular defects in 2013, for example, was about $6.1 billion. It's my pleasure and honor today to host and welcome for the first time in White Coat, one of the outstanding pediatric cardiologists in Southern California, Dr. Merujan Uzunyan, to teach us more about this topic. For interaction with the program, send in all your questions and concerns regarding our today's topic to our official Facebook page, White Coat Alkarma TV. Or if you want to interact with my guest directly, you can call the numbers that will be shown on the screen at any time during the episode, and we'll be more than happy to answer all your questions. To keep up with us, follow our Facebook page, White Coat Alkarma TV, or follow us on Instagram, White Coat Alkarma. And to watch our latest episode, please subscribe to our YouTube channel, الكرمة TV, and activate the notification bell. أعزائي مشاهدي قنوات الكرمة في كل مكان في العالم، بحب أرحب بيكم في حلقة جديدة وخاصة جدا من برنامجكم الطبي الأسبوعي على شاشات قنوات الكرمة وايت كوت. النهاردة هنتكلم على مشكلة بقينا بنشوفها نتيجة زيادة الدقة بتاع التشخيص. المشكلة دي اللي هنتكلم عليها النهاردة هي العيوب الخلقية بالذات في القلب في الأطفال، لأنه الحقيقة المشكلة دي على مستوى العالم بتمثل 1% طبقا للإحصائيات الأخيرة الموجودة في الولايات المتحدة الأمريكية، بتمثل 1% من المواليد، يعني تقريبا كل 100 بيبي مولود واحد منهم بيبقى عنده مشاكل وعيوب خلقية في القلب. الحقيقة من كل اللي بيتولدوا عندهم مشاكل وعيوب خلقية في القلب 25% منهم بنسميها حالات كريتيكال، يعني بتحتاج عملية على طول. وفي بعض الحالات اللي بتبقى عندها عيوب خلقية في القلب يمكن بتحتاج الأول علاج طبي لفترة وبعد كده ممكن نعمل عملية، بيبقى على حسب حالتهم، ولكن المعروف إحصائيا هو أنه 25% من الناس دي لازم تعمل عملية على طول خلال أيام بعد الولادة. نقطة تانية مهمة جدا أنه 15% من العيوب الخلقية اللي موجودة في القلب، 15% من المواليد بنظن أو بنعتقد طبيا أنها راجعة لأسباب جينية، وبالتالي في جزء منها وراثي بشكل كبير جدا. تكلفة علاج الأطفال دول اللي بيتولدوا بعيوب خلقية في القلب، سواء اللي بيحتاجوا عمليات على طول بعد الولادة أو اللي بيحتاجوا رعاية طبية وبعد كده نقدر نعمل عمليات على اللونج ران أو على المدى الطويل، تقريبا 6.1 مليار دولار سنويا في دولة زي الولايات المتحدة، وده حسب إحصائيات 2013. الحقيقة آخر إحصائيات لسه ما نزلتش، يمكن بينزلوها كل 6-7 سنين. فالحقيقة التكلفة دي طبقا لإحصائيات 2013. مشاكل العيوب الخلقية في القلب كانت لفترة طويلة جدا ما بتتشخصش على طول، وبنكتشف يمكن بعد فترة من الطفولة، وفي ناس بتكتشفها. شفنا لعيبة كورة على سبيل المثال بتكتشف ده لما تروح تعمل الكشف الطبي في الأندية اللي بيلعبوا فيها، بيقول له أنت كان عندك ثقب في القلب أثناء الطفولة. مشكلة العيوب الخلقية في القلب إنه هي لو حاجات بسيطة أو ثقب بسيط في القلب إنه بياخد فترة طويلة جدا على ما يتشخص، وإنه البيشنت بيظهر طبيعي جدا في أول فترات سنين حياته. فمهم جدا النهاردة هنتعلم إيه السكريننج اللي نعملها. كمان نقطة مهمة جدا إنه ناخد فكرة عن المشاكل المختلفة أو العيوب الخلقية اللي بتبقى موجودة في القلب. إيه الحاجات اللي محتاجين نتعامل معاها على طول، إيه الحاجات اللي بتاخد فترة، ممكن تمشي بالعلاج فترة وبعد كده نقدر نتعامل معاها. أهم من ده كله في رأيي أنا الشخصي إنه دايما إزاي نتعلم نتكلم مع أولادنا، نفهمهم المشكلة دي إيه، لأنه قطعا هيتأثروا، يعني at certain point هيتأثروا بالمشكلة دي، هيحسوا إن هم مختلفين عن زمايلهم. النهاردة كمان مع ضيفي هنتكلم إزاي نأبروتش أولادنا، إزاي نفهمهم الموضوع ده. كمان إيه الرياضات اللي ممكن يلعبوها، إيه الرياضات اللي مش ممكن يلعبوها، لو في رياضات يعني ممكن يلعبوها، إزاي ده هيأثر عليهم على اللونج ران، على الذكاء بتاعهم، على تعليمهم في المدرسة وطرق استيعابهم، لأنه بعض الإحصائيات بتقول إنه ده له بعض التأثير. كل ده هنتعلمه النهاردة مع ضيفي اللي أنا بتشرف جدا إنه يكون معايا، واحد من أفضل أساتذة القلب للأطفال بشكل عام في واحدة من أعرق الجامعات هنا، جامعة USC. لكل المقيمين اللي في كاليفورنيا عارفين قد إيه دي جامعة كبيرة جدا وعريقة جدا. ضيفي هو دكتور ميروجان أوزونيان، واحد من أفضل أساتذة القلب في الأطفال. زي ما حضراتكم عارفين دلوقتي تقدروا تبعتوا لنا كل أسئلتكم واستفساراتكم على صفحتنا الرئيسية على الفيسبوك وايت كوت الكرمة TV. بأكد كل مرة على الكونفيدنشياليتي بتاع الأسئلة أو المسجات اللي حضراتكم بتبعتوها، بتبقى سرية تماما وبنتعامل معاها بشكل يعني confidential بشكل كبير جدا. تقدروا كمان تكلمونا على الرقم اللي ظاهر قدام حضراتكم على الشاشة لو في أي استفسارات خاصة بموضوع العيوب الخلقية في القلب للأطفال حديثي الولادة أو للأطفال بشكل عام في سن صغير. تقدروا تكلمونا على الأرقام اللي ظاهرة على الشاشة. زي دايما بقول تفاعل حضراتكم والتواصل معنا بيبقى مهم بشكل كبير جدا. تقدروا تتفاعلوا معنا وتتواصلوا معنا، وده بيبقى شكل كبير من أشكال الدعم لقنوات الكرمة. صفحتنا الرئيسية على الفيسبوك زي ما حضراتكم شايفينها وايت كوت الكرمة TV. نقدر كمان نتواصل على البلاتفورم الثانية انستجرام، تقدروا تبعتوا لنا أو تتواصلوا معنا. البلاتفورم الثالثة والمهمة جدا هي اليوتيوب. زي ما حضراتكم شايفين تقدروا تعملوا سبسكريبشن للقناة، نفعل جرس التنبيهات عشان يوصل لحضراتكم أول بأول أحدث ما أنتجته قنوات الكرمة في كل البرامج. تحديدا لو عايزين تتفرجوا على أي حلقة من وايت كوت بنرجع لنفس البلاتفورم، بنروح للبلاي ليست بتاعتنا بتاعت وايت كوت. تقدروا حضراتكم تتفرجوا من خلال البلاي ليست بتاع وايت كوت على كل الحلقات اللي عملناها وغطيناها في المواضيع المختلفة. فتقدروا حضراتكم ترجعوا لأي حلقة من حلقاتنا القديمة خاصة بأي موضوع طبي يكون بيهمكم تتفرجوا عليها. ولكن دايما زي ما بقول التفاعل بتاع حضراتكم مهم جدا عن طريق اللايك والشير للفيديوهات والتعليق. لو في أي أسئلة خاصة بالموضوع يا ريت حضراتكم تعلقوا لنا على صفحتنا أو البلاي ليست بتاعتنا على اليوتيوب، ودايما هنرجع لحضراتكم بالإجابات. بإذن ربنا تكون حلقة مميزة جدا بنتكلم على العيوب الخلقية في القلب الخاصة بالأطفال. معانا ضيف من العيار التقيل، هنستنى تفاعلكم وتواصلكم معانا، ويلا بينا نبتدي فقرات برنامجنا النهاردة من وايت كوت.
So there's a condition called amblyopia, and that's the case in which even with the perfect pair of glasses, the kid does not.
You were born with it, you have it, this is extra.
Pigment is actually important in the pathway from the brain to the eye as the baby is developing in the mother.
People describe a discomfort, usually in the upper part of the abdomen.
Okay.
Very often it's related to meals, so meals seems to make it.
Good candidates for orthokeratology are generally people who have a risk of increase.
When we talk about the problems of, or the definition of ADD, there are three components.
Okay.
They are, of course.
What's regenerative medicine?
Regenerative medicine is a rather new branch within the whole ecosystem.
Mondays never come. Of course, they never come if you're not ready.
Okay.
If you are not ready to make a change, they don't come. And if you're not ready to make the right change, they will
have
never.
a multitude of symptoms, including memory loss, language issues, thought process issues, behavioral.
So if you have high blood pressure, make sure that you take your doctor's advices very seriously. Basically, there are three things that you need to do. One is control your diet. Number two, do some exercise. And number three, see your physician.
But we need to emphasize that there are children who can be diagnosed with arthritis at very young ages.
So majority of people between 30.
Rheumatoid arthritis is a part of arthritis. Arthritis means inflammation of the joint, mean red, hot, swollen joint.
Okay.
Rheumatoid is one part of arthritis out of hundreds of arthritis.
Okay.
And rheumatoid especially is an autoimmune disease, which means the immune system attacking the body.
شارك معانا في عمل الرب في قناة الكرمة بالدعم من أي مكان في العالم عن طريق الكريدت كارد. ادخل على موقع القناة الكرمة.tv.com، اضغط على كن شريكا، ثم اضغط على Buy Credit Card، وبمجرد دخولك على صفحة الدعم سيتحول المتصفح بتاعك إلى متصفح آمن HTTPS. لو حبيت التقدمة دي تكون مرة واحدة اضغط هنا، ولو تحب إنها تكون شهرية اضغط هنا. ادخل مبلغ التقدمة ثم اضغط Next. ادخل بياناتك الشخصية ثم تأكد من أن البيانات المدخلة كلها صحيحة، ثم اضغط على Next. ادخل بيانات الكريدت كارد الخاص بيك ثم اضغط Submit Payment، وبكده تكون شاركت في توصيل كلمة المسيح للملايين حول العالم.
اهلا بحضراتكم مره تانية في فقرتنا الرئيسيه النهارده اللي زي ما قلنا في اول الحلقه هنتكلم على المشاكل والعيوب الخلقيه في القلب في الاطفال تحديدا. ايه الحاجات اللي ينفع نعالجها بشكل طبي، ايه الحاجات اللي لازم لها جراحه، الاعراض اللي لازم نلقطها بدري في الاطفال بتوعنا. كمان نقطه مهمه جدا هي فكره التعامل مع الاطفال في مرحله ما بعد التشخيص. It's my pleasure and honor to welcome for the first time in White Coat Dr. Merujan Uzunyan. Welcome in White Coat for the first time, sir.
Good morning.
It's
very happy to be here.
Oh, we're glad to have you too. Very important topic, congenital heart disease. In the beginning, let's start with the definition. What is congenital heart disease?
Yeah, you know, actually there is a definition. Not that I like that definition, but in essence says is a gross structural abnormality of the heart that or the intrathoracic vessels, so either the heart or the pipes connected to it within the chest, that is actually, meaning at that point or potentially, so that can be in the future, of functional significance. That is this somewhat complicated definition of it. But if we want to break it down, make it simple, speaking of congenital heart defects, we can actually tell that they're based on having a structural defect of the heart. The heart has not formed properly.
Okay. So it's either the building or the plumbing.
Exactly.
The building.
Yeah. Building or plumbing, it's a good way of putting it.
Okay, perfect. حقيقة سؤالي الأولاني للدكتور أوزونيان، وزي ما أنا بقول دايما شرف كبير جدا إن احنا نقعد قدام أساتذة الطب الكبار دول، وبنحاول قدر الإمكان إن احنا دايما نجيب لحضراتكم أفضل يعني دكاترة في كل المواضيع اللي بنتكلم فيها. سؤالي الأولاني ليه إيه هي العيوب الخلقية؟ لو بنقول إنه في عيوب خلقية في القلب للأطفال، إيه تعريف كلمة العيوب الخلقية دي؟ فقال لي الحقيقة إنه العيوب الخلقية دي يا إما بتبقى في تركيبة القلب نفسه، وهنشوف مع حضراتكم تركيبة القلب بتبقى عاملة إزاي بعد شوية، يا إما في الأوعية الدموية المتوصلة بالقلب بيبقى فيها مشاكل. قلت له باختصار شديد يا إما البناء نفسه فيه مشكلة، يا إما زي ما بنقول الأوعية الدموية أو السباك المتوصلة بيه بمفهوم بسيط جدا هي اللي بيبقى فيها المشكلة. So how common are those like congenital birth defects? If you want to walk us through some statistics to know how big is the problem.
Sure. Now, first of all, it all depends on who's counting and how we are counting.
Right.
But the ballpark figure right now is that it's 1.8 to 1, let's say 1, out of every 100 baby that is born with some sort of congenital heart defect.
Okay.
The numbers have been increasing, and we're talking about increasing since the 1930s when they first started looking at those. But I think it's firmly believed, I shouldn't say firmly believed, it is believed that the increase is based on better diagnostics, not that the incidence of these conditions have really risen. So now we have ultrasonography.
Okay.
Therefore, the number is around 1 out of 100.
Okay.
But considering that a lot of tiny defects are missed because they're not investigated or they're not looked
diagnosed
at. So it depends. I think if you look in a major medical center with ultrasonography, some do that, ultrasound everybody, all the newborns, then you will find that the incidence is a little more than that, maybe 3, 4 out of 100.
Okay.
But 1 out of 100 is, I think, a good number. So that comes down to around 40,000 babies in America. There are around 3.94 million live births in the USA as of, I think, 2017, 18, last number. So around 4 million. So 40,000 of them are born with some sort of congenital heart defect.
Okay. Any statistics about life expectancy for those babies?
Sure, and life expectancy is changing tremendously now, standing with the fact that the non-complicated conditions, small holes in the heart, things like that, or that mild valvular problems that known to not cause problems, and a lot of small holes in the heart that actually self-resolve if we don't count them, because their outcomes won't be any different between now and the past. But with the advances in surgery and intensive care, post-surgical intensive care in advanced countries, not available everywhere, unfortunately, all around the world, we can see that now even the most complex of the cardiac conditions, there is a 1-year survival of close to 85%.
Oh, wow.
Some institutions will actually tell you that it's close to 92%.
Wow.
That is first year. And then around 80% of them, they actually reach adulthood right now. So what we are having is that the number of adults that are living survivors of congenital heart defects, especially the complicated ones, so to speak, the severe ones, is rising. So now at this point, as of I think a year or two ago, the number of congenital heart defect bearing adults, has surpassed the number of children that have. So we're, I think, 1 million children right now in the United States, more or less, and 1.2 million, let's say, adults that are living with some sort of congenital disease that allowed their survival.
Okay. I have a question here on our social media. First question they're asking you is atrial fibrillation, a baby who's born with atrial fibrillation, is considered a heart birth defect?
Well, first of all, atrial fibrillation is incredibly rare in a baby.
Okay.
But there are other arrhythmias that are, again, rare, but possible, and we see them actually. We end up seeing around 4 to 6 a year. Believe it or not, that is a very big number because they're rare. But there's the so-called neonatal or fetal even. So the rapid heartbeat that would be sometimes, depends on what they're calling atrial fibrillation, if it's adult asking the question. But for the baby to be born with atrial fibrillation is very rare. There are other arrhythmias, so-called atrial flutter, another form of tachycardia, and SVT, supraventricular tachycardia, and subsets of it that might not be the place to discuss them. But so atrial fibrillation is very, very rare, super rare.
If there is atrial fibrillation, should we look for like a primary reason for it, or it can be a primary?
Yeah, usually the arrhythmias, let's say the ones that we actually see are the ones that are known to be much more common than atrial fibrillation in the fetus or newborn, because fetal and neonatal arrhythmias kind of overlap. You might either have it as a fetus or right after birth. And they're usually the ones we're talking about now are tachyarrhythmia, so rapid heartbeats.
Okay.
And usually, I shouldn't say, yeah, maybe, overwhelming majority happen to normal hearts, meaning structurally is normal, just going fast.
Okay. الحقيقة سؤالي لدكتور أوزونيان كان عن قد إيه الموضوع ده common أو يعني بيحصل. برضو زي ما اتعودنا مع حضراتكم جزء مهم دايما بنتعامل فيه في كل موضوع هو فكرة الإحصائيات. زي ما هو قال لي انه تقريبا بيحصل في 1 في كل 100,000 حالة ولادة بتحصل في الولايات المتحدة. احنا طبعا لما بنتكلم على إحصائيات غالبا الدولة الأفضل في العالم في الإحصائيات بتبقى الولايات المتحدة، فالموضوع بيحصل مش رير ولا حاجة. زي ما قلنا مع حضراتكم قبل كده انه تقريبا عدد لو قلنا المواليد من 3 ل 4 مليون يبقى تقريبا 400,000 بيحصل كل سنة تقريبا بيتولدوا بمشاكل صحية أو عيوب خلقية في القلب. نقطة تانية مهمة جدا، زي ما أنا قلت إنه دايما التكلفة الطبية بتبقى جزء مهم جدا من الإحصائيات. 6.1 مليار دولار كل سنة بتبقى تكلفة علاج الأطفال دول بشكل كبير جدا. سؤال برضو جالنا على السوشيال ميديا، بيسأل أو بتسأل إيفا على ال atrial fibrillation. زي ما قال دكتور أوزونيان، atrial fibrillation very rare إن احنا نلاقيه سبب من العيوب الخلقية، ولكن دايما ندور على السبب أو اللي سبب ال atrial fibrillation. ولأعزائنا المشاهدين، atrial fibrillation ده نوع من النبضات السريعة اللي بتحصل في القلب، بتبقى من يعني فوق ال 100 ل 150 دقة في الدقيقة. فالقلب بيزيكلي بيدق بشكل سريع جدا، ولكن ما بيحصلش الانقباض المطلوب في الدم، فبالتالي بيبقوا مرضى الاتريال فايبريليشن عرضة للجلطات على المدى الطويل لو هم كبار. في الأطفال very rare ان احنا نلاقي الاتريال فايبريليشن بيحصل. زي ما قال دكتور أوزونيان 6 حالات على مستوى يمكن العالم في السنة ولا حاجة. فمهم جدا ان احنا ندور ليه حصل الاتريال فايبريليشن. طبعا لازم نعالجه، ولكن مهم ندور على السبب اللي ادى لحدوث الاتريال فايبريليشن. hopefully نكون كده جاوبنا سؤال حضرتك. So if we can go over like a diagram for the heart and let us know simply like the structure of the heart and how the blood goes in general, then if you can talk to us about the main reasons and contributing factors for those like congenital heart disease.
Sure.
So if we have slide 11, for example, we can use it as a reference. And if you can explain to us how the blood goes in the heart.
Which one? Let's go back to 10 maybe.
Yeah.
For a second. I think what we can do, we can quickly go through 2 separate but connected topics. One is the fetal heart, so the heart before we are born, so to speak, and then the heart after we are born. Why is the difference? Well, the main thing is that in utero, meaning when we're not born yet, we obviously cannot breathe, cannot use our lungs. Therefore, oxygen has to get to the baby in a different way. So that is done through the oxygen exchange between mother and the baby through the placenta. So therefore, the placenta is the organ of oxygenation and obviously not the lungs. So now that means we are actually speaking of, let's say, pumps and devices and oxygenators instead of the human body. We are basically adding an organ now while during pregnancy, and we are not using our lungs. So to be able to plug in the placenta, so to speak, we have different pipes.
Okay.
So the so-called the pipes that come back or bring back blood from the placenta, oxygenated blood, and then vessels, pipes that go from the fetus to the placenta to bring back the blood that needs to be oxygenated and filled with nutrients.
Okay.
Now those have to come back to the heart. Of course, the heart, the blood has to come back to the heart. Therefore, we have 2-3 detours. That's the main deal with the fetal heart. First of all, there is an opening within the heart that is functioning in the fetus to allow blood to go from the right to the left side. So blood that comes back from the placenta basically has to be distributed to all of the organs. This blood is the best oxygenated blood possible that the fetus can receive. And some organs have to be prioritized, believe it or not. So the liver somehow, of course, is a very big synthetic organ, makes a lot of things, is a factory. So liver needs good oxygenated blood. But if we plug in the return from the placenta first to the liver and wait for the blood to go through the liver and then enter the heart, the liver will consume everything. It will be pretty greedy. So therefore, we have something called the ductus venosus. It's a little pipe, right, between the pipes that come back from the placenta and the heart. That is the first detour, let's put it that way. So basically, that one allows the liver, part of the liver, to get clean oxygenated blood, but the rest of the oxygenated blood escapes the liver, so to speak, and then now enters the heart. Once it enters the heart, goes to the left side. That blood specifically goes to the left side, the one coming back from the placenta. Well, why are we sending it to the left side? The concept is that from the left side, we actually perfuse the aorta, the main pipe of the body. So the very first organ then to receive, in that case, oxygenated blood will be the heart itself, the coronaries.
Right.
And the second one will be the brain. So I think that's the other detour. So one is the so-called ductus venosus, the other the opening within the heart.
And they start piping the oxygenated blood to the rest of the body.
Right. And then another trick is that the right side of the heart, on the other hand, is going to receive deoxygenated blood and some oxygenated also. So the head and neck vessels, the blood that comes back to the heart from our head, arms, and upper chest, goes to the right side of the heart, preferentially. A part of the blood that comes from the placenta that didn't actually cross the midline also goes to the right. So it's less oxygenated, so to speak.
So the left side is more oxygenated than the right
instead of the right. And the right side then pumps in the adult or in the newborn even. The right side is in charge of pumping blood to the lungs. That doesn't need to be done to that extent in the fetus. So the lungs get only a small portion of the total cardiac output. And then now we have the third detour. The third detour, we call it the ductus arteriosus. We can actually make a little drawing for it too.
Sure.
And then that pipe now from the right side takes most of the non-oxygenated blood and technically sends it to the lower part of the human body, legs, intestine, kidneys, and but mainly back to the placenta to be oxygenated.
Okay.
So, yeah, go ahead.
So, relative to that, like our heart, like adult heart, if we went to slide 11, what are the changes that happen from childhood to have the regular heart that we have now?
Yeah, sure. Now, things happen fairly quickly. So right after we are born, and assuming we are not born prematurely, as a detail, so to speak, then all these detours will disappear very quickly.
Okay.
Technically, they won't allow any significant amount of blood to go through those three separate detours or tunnels, so to speak. So the ductus venosus closes, the door, the flap within the heart kind of closes for changes of pressures that happen in the heart and then seals off. And the so-called, the other pipe that connects the pulmonary artery to the aorta, the ductus arteriosus, also within the first few days of life disappears. So at the end,
it turns out to that like diagram we have now,
right,
the regular heart.
At the end, we go from a heart that has a flap inside and a couple of pipes outside connecting the plumbing, so to speak, to a heart that has no holes inside, and the pipes outside the heart do not communicate with each other.
Is the aorta and pulmonary?
Right, they're completely separate right now.
Okay. الحقيقة برضو عشان حضرتك وهحاول طبعا ألخص الشكل العلمي اللي قاله دكتور أوزونيان باختصار شديد. ولسه يعني الطفل في بطن أمه بيبقى المشيمة هي المصدر الرئيسي للدم، المشيمة اللي بتبقى موصلة الدم بتاع الأم للطفل. لو جبنا سلايد 10 هنشوف إنه المشيمة هي الأساس في الدم ده كله. بيروح يعني لبايب لاين معينة بتوصل ده للناحية الشمال بتاع القلب، وبيبقى كله دم فيه أكسجين. بعد كده في بعض الأوعية الدموية بتتوصل بالناحية اليمين بتاع القلب، بيبقى الأكسجين أقل شوية، ولكن القلب بيبتدي يضخ الدم اللي فيه أكسجين ده لباقي أجزاء الجسم. لو رحنا للسلايد اللي بعدها هنلاقي إنه القلب عبارة عن 4 حجرات زي ما بنسميه. كل حجرة فيهم بيبقى فيها وظيفة. الحجرة اللي بنسميها حجرتين بنسميهم الأذين، وحجرتين بنسميهم البطين. بيزيكلي يعني الأذين الأيمن بشكل عام بيرجع كل الدم اللي مش ما فيهوش أكسجين ليه يضخه للبطين الأيمن، وبعدين البطين الأيمن يطلعه للشريان الرئوي اللي بيروح للرئة بشكل كبير. بيتم فيها تبادل الأكسجين ويرجع الدم اللي مليان أكسجين للأذين الأيسر، يضخوا للبطين الأيسر اللي فيه شريان مهم جدا اللي هو الشريان الأورطة. المفروض إن كل ده يحصل ومفيش أي ثقوب موجودة في القلب، مفيش كمان أي اتصال ما بين الشريان الرئوي والأورطة، لأنه كل اللي أنا بقوله ده هيبقى عيوب هنناقشها بعد كده في جزء العيوب الخلقية بتاع القلب. So what's the health impact of the congenital heart disease in general?
Well, health impact, again, will depend on the severity or gravity, complexity of the congenital heart defect. It can range from literally, so assuming someone is born with a heart defect, we can start looking at it in a way that if it's a very simple defect, tiny hole, couple of millimeters, 3-4 millimeter hole in the heart, either between the two pumps of the heart or between the two collecting chambers above the pumps, those would be really silent, meaning we can still hear them if we examine, but we'll have very negligible, if any, impact on the person. And then you go up gradually, so take the same defects that now and make them larger. So if those holes are larger and they reach a certain size, then they would have an impact to even require surgery.
Yeah.
So it all depends on where the defect is and even the simple ones.
I think they classify them to 25% critical, which needs like surgery right away.
Right.
75.
You know what it is, that the 25% is the so-called critical congenital heart defects that are actually far more complicated than, let's say, what we would call an ASD or VSD, so the simple holes in the heart. And we can go through them. We can even make some drawings.
We'll go through them one
yeah.
by one. I just have a question here on our social media. 3-month-old baby, he was diagnosed with VSD, 2 millimeters. She's asking, her doctor told her it will close eventually. She's worried, the mom is worried and asking, that's true, should she wait? Is there any intervention can be done at the moment?
No, look, assuming is 2 millimeters, then that will not be a problem. Mom has to just relax.
Okay.
And again, depends on if it's muscular within the muscles or right after the valve. So there are different locations, but regardless, I think 2 millimeters in a 3-month-old, it's gonna go away.
Okay. الحقيقة برضو مدام صفاء هنا بعت لنا سؤال، بتسأل انه ابنها 3 شهور اتشخص بثقب في القلب ما بين البطينين زي ما بنسميهم. الثقب ده من 2 ل 3 مليمتر، وبتسأل إذا الدكتور بتاعها قال لها إنه ده هيقفل لوحده eventually زي ما دكتور أوزينيان قال في السايز ده، ولو هو موجود في العضلة نفسها بتاعة البطين، أنا آسف، ما بين البطينين، فده 2 ل 3 مليمتر عادة بيقفل لوحده. فزي ما هو بيقول يعني ريلاكس، ده مش سايز كبير ومش هيأثر بشكل كبير على ابن حضرتك. What are the most common causes or contributing factors for congenital heart disease?
Yeah, what we know so far, I'm sure there is obviously important genetic factors that we don't routinely test for, and we're getting more and more knowledge about the genetic factors involved in the congenital heart defects.
And I think it's 15 to 20% are
it is said. I have to think it's going to be more than that.
Okay.
But what it is that, you know, the genetic basis, of course, for all the information necessary that is kind of written in our genetic system will work to make a normal heart, let's put it that way.
Right.
The interaction of the genetic products and the environment in which the baby is growing, then the hemodynamics that actually is created by certain defects can lead down the line to further abnormalities. Let's say there is a valve that is not forming properly, then blood is not going to go through that valve properly in the fetus, and downstream structures can be affected too. Kind of part is hydraulics, so is genetics driving the hydraulics, or hydraulics affected by genetics. But genetics is one thing. Then maternal diabetes is another one that it's well known. Maternal febrile illnesses and like rubella infection in utero of the baby. And some medications, especially lithium, we always hear about lithium. I yet have to see a case of lithium and Epstein's, but it's a well published, in a sense that well publicized. Everybody knows, they ask you on your boards, but.
What about smoking? Does it have effects?
No, unfortunately, well, I should say unfortunately, meaning would have been another good reason to tell people to completely stop smoking. But I don't think that there is enough data to say that smoking causes congenital heart defect. But
it causes other stuff.
Yeah, in the baby, and there's no, remember, we have all those detours in the heart, the pipes that respond to oxygen, respond to other mediators. So cigarettes, even alcohol, we don't have really evidence that alcohol per se causes congenital heart defects. Actually, you might find some reports that there is a higher incidence of ASTs, but it's impossible to tell. You have to really look at a lot of babies that are for sure exposed to alcohol.
And a lot of other variabilities
yes,
as well.
And then you have to look at all that. And AST is fairly common and very common to not have it diagnosed as a newborn or as an infant, even child. A lot of ASTs, you know, atrial septal defects come to our attention where I work at, actually in teenage or even adults, because they're completely undiagnosed before. It's difficult to diagnose.
Another question here, 27 years old, pregnant woman. She's like at 32 weeks, and she's taking labetalol for her blood pressure. She's asking if that medication specifically can lead to any kind of congenital heart disease.
No, especially at that time. See, depends. Well, no, labetalol not known to cause problems, but and especially at 32 weeks, the heart is completely formed. Actually, it's completely formed by almost 50 days of pregnancy.
Oh, okay. So after 50 days of pregnancy, the heart is formed.
Yeah.
Okay.
So embryology is completed. Now you may, and then the labetalol at this point won't really harm the structure of the heart.
Okay. Do we have a critical period during pregnancy where anything can really affect the heart?
Yeah, unfortunately, is when you probably don't know that you're pregnant. Let's put it that way. You know, we're talking 30, 40 days.
Weeks,
yeah, exactly. So it's that's when the heart forms. It's actually a fascinating organ because has to form, of course, like every other organ, but has to feed itself and then feed the rest while getting to reach its
like the mom
very
for
complex
the
form. You know, we don't realize how complex it is because we make diagrams and we study anatomy, but it's fairly complicated piece of muscle. Let's put it that way.
Perfect. الحقيقة سؤالي لدكتور أوزونيان كان عن الحاجات اللي بتساعد أو المسببات اللي ممكن تسبب عيوب خلقية للأطفال أثناء الحمل. فقال لي انه تقريبا العيوب الخلقيه اللي بتحصل نتيجه انها جينيتكس بتيجي من الاب والام حوالي من 15 ل 20%. بعض المسببات الواضحه زي الادويه نتيجه الليثيوم. الليثيوم اللي بياخدوه كل الباي بولر والسكيزوفرينيا بيبقى له سبب واضح وبيعمل مشاكل في القلب بشكل كبير جدا. كمان السيدات اللي بتبتدي الحمل يعني زي ما بنقول مع سمنة في البداية أثناء الحمل ده ممكن يعمل مشاكل في القلب بشكل كبير جدا. السيدات اللي عندهم سكر أو اللي بيحصل لهم سكر حمل ده برضو ممكن بيعمل مشاكل كبيرة في القلب بشكل كبير. التدخين والكحوليات مش معروف انه يعني ما فيش ستاديز عليهم اناف ان هم يثبتوا ان هم بيعملوا حاجة في القلب، ولكن هم طبعا مضرين في حاجات كتير، ولكن تحديدا مش معروف قد ايه بيأثروا على تكوين قلب الطفل. معلومة مهمة كمان قالها دكتور أوزونيان، إنه قلب الطفل بيتكون بعد أول 50 يوم، يعني تحديدا بعد أول 7 أسابيع من الحمل. ودي بتبقى مشكلة لبعض السيدات إنه ما بيعرفوش إن هم حوامل غير بعد فترة تقريبا، عادة بنتكلم بعد 4 ل 6 أسابيع مع انقطاع أول دورة، فبالتالي ما بيكونوش عارفين إن هو حوامل، وأحيانا بياخدوا حاجات بتأثر على قلب الطفل. ف يعني unfortunately بعد الحاجات بتحصل أثناء عدم معرفة السيدات بفكرة الحمل، وده بيعمل مشاكل كبيرة زي ما بنقول لقلب الطفل. كريستين بعتت بتسألنا سؤال، إنه هي ضغطها عالي أثناء فترة الحمل، وهي عندها عندها 32 أسبوع في فترة الحمل، وبتسأل إن هي بتاخد دواء اسمه لابيتالول. فسألت دكتور أوزونيان عليه، قال إنه لابيتالول تحديدا من الأدوية اللي ما بيأثرش على قلب الطفل تحديدا، فما تقلقيش يا كريستين. كمان 32 أسبوع بيبقى اوريدي قلب الطفل اتكون بشكل كبير جدا، وبالتالي ما فيش خطر من اللابيتالول بشكل كبير جدا. I want to ask you a question here because it's very important. What's the earliest symptoms and signs we can catch with congenital heart disease, and do every single child with congenital heart defect need to turn blue?
Oh, no, that's a great question. Actually, let's address it this way. It's going to be a long answer.
Oh,
but,
yeah.
Again, there's so many different kinds. For the, put it this way.
You want to classify them cyanotic versus acyanotic?
No, I can't. Another way of looking at it, yeah, sure. But what I was trying to say first is that, unfortunately, there are conditions, any other disease kind of, it's also, we can look at it from that angle. What I'm trying to get to is that there are conditions that some are simple defects, some are very complicated.
Okay.
The complicated ones, the average person won't know what they are until, unfortunately, you're confronted with a child,
right,
your own child that now has it. Then that's one thing. But so going back to their symptomatology, the presentation can actually be in utero,
okay,
meaning during pregnancy. But it would be obviously no symptoms whatsoever. Would be accidental or not so accidental because of part of prenatal care here in the United States, ultrasound. So our obstetrics and maternal-fetal medicine colleagues have their own protocols, well established, where they have to see the so-called 4-chamber view.
So what we call it early screening for congenital heart defect.
And it is a 4-chamber view, like the picture that we kind of had on the screen. That's you'll see the heart that looks like a Valentine's Day card picture of the heart with 4 chambers. And but to that has been added another part where now they also have to see what we call the outflow tracts. To make it simple, you have to see the heart in all of the chambers of good size, 4 good size, like a house with 4 good rooms.
Okay.
And then you have to see 2 doors, meaning the 2 doors going out of the heart have to be visualized too. In case that is not done, meaning in case that is not normal, any of those that don't look normal to the obstetrician, then a referral to pediatric cardiology is done, and then we look at it with a complete echocardiographic exam. So congenital heart defect, structural defect, can be picked up that way.
And that's the skeletal test at 19 to 20 weeks? Usually?
Right, around 19, 20 weeks, yes. Okay. And now, that's one. The other one is little further during pregnancy, 24, 26 weeker, where the arrhythmias start, like earlier question about the atrial fibrillation, again, being rare, but other arrhythmias being far more common. Then those arrhythmias, again, will be detected accidentally. The mom goes to the doctor, they put a monitor, they don't even have to look. When they have to hear a heartbeat, and suddenly now the baby is going 300, therefore. Okay. So fetal arrhythmias are detected, again, in a mom has no symptoms, of course. So then the structural defects accidentally in that way, or by either routine screening look during prenatal care. After we are born, after the baby is born, again, the very wide range of problems, in a sense that the congenital heart defects can present. Here, there is, maybe we can show this slide here. Slide, I think 17.
Okay.
So either is prenatally diagnosed, let's put it that way. Now, I do prenatal diagnostics also, fetal medicine, but that doesn't mean I'm correct all the time. So I have to admit that prenatally diagnosed, the diagnosis can be correct, incorrect, somewhat correct, let's put that way. Most of the time we're correct. We're able to detect almost any congenital heart defect with ultrasound this time and age.
Okay.
Now, we obviously we confirm that postnatally, but that opens also another topic. Quickly, we can go into that. If you diagnose something prenatally, then what do you actually do with it?
Okay.
Again, it depends on where you are, what are the means, what are the resources. Believe it or not, the average, people won't know out in the community, especially not in the States or places where very advanced medical care is available. There are even fetal interventions for some.
So we can fix some of them intrauterine.
But it's still like in the pioneering stage in very selected facilities and very select conditions that probably don't need to get into. But so one thing is fetal intervention. If we leave that aside, then the other difficult topic is, does this pregnancy need to continue?
Right.
So termination, non-termination. Therefore, from our standpoint, from pediatric cardiologists now, is becoming more difficult, because when surgeries were not available,
what we're going to do.
we weren't even able to look in utero.
Right.
So it was a moot point. Baby was born, baby had A, B, or C, and the outcome was whatever was for the times being. Now there is prenatal diagnostics and postnatal surgeries, even for the most complex form of congenital heart disease, surgeries are available with variable outcomes. So it's becoming more difficult to, so you have to have your own knowledge base, you have ethics, you have your own everything, religion, the whole nine yards. And then being able to tell the family, give all the information,
and they can
expect them to make a decision. But on the other hand, I put myself in their shoes, the complexity of the condition, and then is it really correct to let them make the decision? I'm still struggling with
that. Okay. So I'll translate this part, then we can go back, talk about the symptoms and signs that we can. الحقيقة كان سؤالي لدكتور أوزونيان، امتى بنقدر نكتشف العيوب الخلقية دي في القلب؟ قال لي واعتقد انه التست ده موجود في كل حتة في العالم. طبعا بيختلف بمدى تقدم الدولة او الامكانيات الموجودة، ولكن تيست مهم جدا تعمله كل سيدة أثناء فترة الحمل. طبعا هنا بيتعمل اوتوماتيك عن طريق الانشورنس، مش عارف برضو في باقي الدول ايه القصة، ولكن التيست ده بيزيكلي بنبص على الأطفال في الرحم وهم موجودين من سن 19 ل 20 أسبوع. في تيست تاني بيتعمل 24 أسبوع، بنبص على القلب، هل هو الأربع حجرات متكونين بتوعه، هل هو الدم بيروح من في الطريق الصحيح بتاعه، هل في أي ثقوب في القلب أو الكلام ده. زي ما أنا قلت مهم جدا 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 من 19 ل 20 أسبوع بنبتدي نعمل التست ده هنا، وعند 24 أسبوع بنعمل الجزء الثاني وبيتكتمل الصورة تماما. فالحاجات دي بتتشخص قبل الولادة. كمان دكتور أوزونيان قال إنه في بعض الفاسيلتيز المتقدمة جدا هنا في الولايات المتحدة بيبتدوا يعملوا عملية في القلب أثناء والطفل موجود في الرحم لسه في رحم أمه، ولكن ده طبعا exceptions موجود في facilities متقدمة هنا، مش موجود حتى في كل الأماكن في الولايات المتحدة الأمريكية. still سؤالي ليه هو ايه الأعراض اللي الأم ممكن تلقطها بدري جدا في طفلها ونقدر نقول إنه الطفل ده ممكن يكون عنده بعض المشاكل في القلب. So still our question is the early symptoms and signs that any mom can notice very quick and she can ask for doctor's help predicting that there is some congenital heart defects.
Sure. Now, again, we can break it down to also where we are.
Okay.
And then the complicated ones, the complex ones, will be most likely detected, hopefully, before the baby actually goes home.
Okay.
Now, let's start with the simple ones then. And
Right.
what are the modalities of presentation?
And when we say the simple one, which is the ones the baby doesn't have to turn blue.
Right.
Am I right? Okay.
Yeah. Again,
Perfect.
not, well, we can say that way. Now, there are obviously two big categories for everybody. Med students, doctors, we all go that way. And we say cyanotic, that means the baby turns blue, or non-cyanotic. Okay. It's a kind of simplified way of looking at it. But there are non-cyanotic conditions, technically, that can actually present also in the newborn,
Okay.
and they're fairly severe.
Okay.
But if we stick to the common things, common knowledge, non-cyanotic, non-blue babies.
Okay.
So we can break it down with AST, so hole within the upper chambers of the heart.
It's actually, we have it in slide 25 here.
Yeah.
If you can, you said that it would be a hole in...
This one.
Okay.
Yeah. Like that would be the AST, a hole between the top two chambers of the heart.
Okay.
And that can be of variable size. Then the next defect would be the next slide, slide 26, where there would be a hole between the two pumps that are the lower chambers of the heart, where the muscle, the pumping chambers are.
Okay.
That we call it ventricular septal defect. And again, can be varying size. And then third one of another so-called simple lesion would be the so-called PDA, in short, by the patent ductus arteriosus. And that's actually is the same connection that in the fetus connects the right and left sides, kind of the pulmonary artery and the aorta. So those are the three simple defects.
Okay.
And obviously the combinations of those are also possible. A baby can have two of them or three of them. At the end of the day, though, what it is that blood through those connections goes from the left to the right within the system. When we say left to the right, means that the lungs then would be right side being connected to the lungs. See blood going left to right. So there is extra or excess blood, more than necessary, more than called for blood going actually to the lungs.
Okay.
So we can keep it simple this way, based on the size of the defects, the amount of blood that goes left to right, the lungs will be overloaded with fluid, with blood, to a varying degree.
I have questions here about those simple
Sure.
ones. What are the early is there any early symptoms?
Yeah,
and
now,
signs we
if
can detect?
usually the first few days, even 2-3 weeks, the baby might be completely asymptomatic,
Normal, okay.
even silent from an auscultatory standpoint, meaning even if the doctor listens, won't be able to detect the holes, because right at birth and for a few days, even a few weeks after that, the right and left-sided resistances and pressures, the lungs have very high resistance, blood resistance. We're talking resistance to blood flow. It has nothing to do with our breathing.
And those we can detect them even during those tests at 20 weeks and 24 weeks?
Meaning in utero? Oh yeah, we can detect them, sure. Not the
even they're
AST,
small.
because the flap, the opening in the two sides, like slide 25, the opening between the two sides of the top chambers is normal in utero.
Okay.
Unless the whole wall is missing, we can't diagnose that.
So the ASD we cannot detect sometimes?
No, and the PDA also, because normally present. The
Okay.
PDA actually
Right.
is a must
It just didn't close,
in utero.
yeah.
So the VST we can. So the simplest defect that we can diagnosed in utero would be the VST, let's put it that.
So the first 2-3 weeks can be normal, even to auscultation.
Right.
So what are the early symptoms and signs?
And you know, it's a very common, it's the one very common that is not heard, and then the next doctor hears it, and then the parents get upset. It's
the
very
first
common.
one is
That
a bad
doctor
doctor.
didn't tell me anything, but that's the thing. The pressures is like having two walls connected by a hole. I mean, two rooms connected by a hole where blood has to go left to right, but at the beginning it's just going this way, so to speak, because the resistances are the same.
Okay.
So the pulmonary resistance, lungs, blood flow resistance goes down in the first few weeks of life,
and then
that's when the baby reaches like adult physiology, so to speak, even if it's still a tiny baby.
So what are the symptoms that can be?
Symptoms would be based all on the fact that the lungs are congested.
Okay.
So congested, we're talking
like
about
a lot of blood goes to the lung.
so lungs get heavier, let's put it that way. So to move a heavy lung is like a sponge that is dry or sponge that is soaked with water, heavier. So the baby now has to move heavy lungs. They have very thin-walled compliance lung, chest wall. Therefore, this is what the family is going to see. Baby is going to breathe fast.
Okay.
So these babies breathe fast, and we're talking in the rates of 40, 50, 60 even. And then under the ribs goes in and out. Most of the babies are actually pretty happy. So we call it happy tachypnea, happily fast breathing baby.
Okay.
They don't turn blue. Then they start sweating with feeding. So it's all degrees now.
Okay.
If the hole is big, too much blood is going from left to right, proportionately more and more. Then that's going to be rapid breathing, sweating with feeds, especially when they're eating, and not gaining weight. And also then we physicians will hear it, of course, and the baby's liver gets bigger. Mainly is the baby that tires, has to come off the bottle or the breast, cannot eat for the 10, 15, 20 minutes, has to come out for air. So those are things that moms are going to notice.
Okay. And of course, doctors have to take a good history. One of the things I learned from you personally is 90% of the diagnosis is history.
If given properly and taken properly. Otherwise, what I say, 80% of the misdiagnosis is the history. But I mean, yeah, you're right.
Perfect.
History is important.
اوكي الحقيقه هنتكلم على العيوب الخلقيه البسيطه اللي زي ما بنسميها. في نوعين كبار من العيوب الخلقيه في القلب في الاطفال. النوع الاولاني بنسميه السياناتيك، او انه البيبيز دول بيبتدي يعني لونهم يزرق، وده بيبقى تقريبا في اول يوم في الولاده، وده بيبقى الانواع المتقدمه دي او اللي بنسميها كريتيكال. بيبقى من السهل جدا ان احنا نلقطها بدري، لانه زي ما انا بقول بشكل كبير جدا البيبيز دول بيبقوا بيزرقوا على طول بعد اول يوم من الولاده، وبنقدر نلقط الموضوع ده بدري. في انواع تانية من العيوب الخلقيه اللي هي بنسميها العيوب الخلقيه البسيطه، او اللي مش كريتيكال زي ما بنقول، اللي هي بتبقى 3 عيوب خلقيه شهيره جدا. اولهم اللي هو ثقب ما بين الاذينين، ويمكن لو جبنا الصوره مع بعض بيبقى الحجرتين العلويتين فيهم سلايد 25 بيبقى فيهم ثقب ما بين الاثنين واضح جدا. النوع الثاني بيبقى الثقب ده موجود ما بين الحجرتين السفليتين اللي هو بنسميهم البطينين اللي هو بنسميه الفي اس دي. والنوع الثالث بيبقى الثقب ده موجود ما بين الشريان الاورطه والبلمونري ارتري او الشريان الرئوي، ودي بنسميها بيتن داكتس ارتريوزس او بي دي اي. الحقيقه مهم جدا في ال3 عيوب دول انه بما انه البيبي ما بيزرقش في سن مبكر، انه الام تبقى يعني زي ما بنقول شاطره انف انها تلقط السيمتومز البدري. اولها على الاطلاق ان البيبي ده بيبتدي يتنفس بسرعه جدا، اسرع من الطبيعي او من اي بيبي تاني. الحاجه الثانيه المهمه انه دايما مع كل رضعه انه البيبي ده بيبتدي يعرق بشكل كبير جدا. الحاجة الثالثة انه طبعا زي ما بنقول بنلاقي البيبي ده يعني ما بنسميهوش باللغة العربية ما بنسميه يعني بنسميه انه ما بيبقاش سعيد. دايما الطفل ده بيعيط بشكل مستمر فمهم دايما ان احنا ناخد بالنا من الحاجات دي. طبعا لما بيروح للدكتور للاسف انه في اول اسبوعين 3 ممكن الحاجات دي بتعمل حاجه اسمها ميرمر، ما بيتسمعش بشكل كويس في اول اسبوعين 3 وبعد كده بيبتدي يظهر بشكل واضح جدا. حتى يعني دكتور أوزونيان قال انه الناس بتقول انه ممكن الدكتور الاولاني اللي سمعه ده مش شاطر، ولكن فعلا بنأكد لحضراتكم انه ممكن في اول اسبوعين 3 ما بتبقاش مسموعه، ولكن الاعراض دي بتبقى واضحه. فمهم جدا انه الدكتور ياخد هيستوري بشكل او ياخد تاريخ مرضي من البيشنت بشكل كبير جدا. So the cyanotic one, we can observe from early. Baby turns blue very early, so it's easier to diagnose.
Well, again, you know, yes, has to be, but it is not. Has to be, but it is not. I'll tell you why. The level of blueness, so to speak, it's very relative. It depends on actually the light in which you are observing, and we are really in environments with fluorescent light in our lives, so it makes it a little bit more difficult. The baby's skin color, skin complexion might make a very big difference. So just actually true examples of last 3 weeks, 4 weeks, we had 7 really very complex hearts being born in our hospital.
Yeah.
Whatever kind of coincidence that was, for 7 of them to come in only like 1 month, because they're pretty rare. So mainly were high-risk pregnancies, so they were sent to be delivered at our center. But out of those, every single one was a cyanotic condition.
Okay.
4 of them were saturating 96% without any oxygen help, and happy babies. So we knew their diagnosis in utero. So I think prenatal diagnosis, it's very important because of that. In a resource-rich environment where things can be done, it's better to know what's coming out than not, because then you're ready. Because those babies, if we go back 15 years even, where I am now, further back, babies like that were actually discharged home to present at day 4 or 5, we can go through it in a minute, in literal terminal, like cardiogenic shock, that they need to be rescued because there are complications. But let's say the simple answer is that if we take it as face value that a baby is blue, then we should be able to
diagnose it.
But they've done studies actually published way back. They took pediatricians, neonatologists, pediatric cardiologists to observe babies that are actually cyanotic, known to be cyanotic. That means their oxygen saturation is testing below normal. And I think they could detect it. What I mean is everybody was able to detect it only when the oxygen saturation was below 75.
Okay.
That's obviously blue. But you're running 85, 88, 91 is abnormal, 92, you won't know.
Okay. I have a question here. How soon the cyanotic and acyanotic needs to be treated?
Yeah.
And medical management would be okay for some of them?
So cyanotic disorders, again, we have to break down different categories. Cyanotic or also non-cyanotic, there are conditions where, so we go back to the way the circuit works. We have the right side pumping to the lungs, left side pumping to the body.
To the body, yeah.
And then now the anomalies, the malformations are very variable. But if either one of the sides is obstructed, let's make an example that the pipe, the aorta, the pipe, the long pipe that comes out of the heart and then perfuses the whole body, is really squished down at a certain point, then the lower body depends on blood that comes from that other pipe that in the fetus is open. So this baby, if we just look at the baby, will be completely undetectable as a newborn. We'll go home, and then disaster will strike when that pipe, the ductus arteriosus, closes down. Therefore, the lower part of the baby will receive no blood. Baby will then present in what we call shock, cardiogenic shock. That would be the critical coarctation. So But the good news is, at least here, meaning as a policy, as a guideline, we do check every single baby's oxygen in the newborn nursery before they go home, 24, 48 hours of life. We check oxygen saturation in the right hand or right finger and one of the two legs, because those critical conditions where demise might happen within days of being discharged home would present with varying different a gap between the higher oxygen in the arm than the leg, so to speak.
I have a question here from Germany, 17 years old male, and he's trying to play like a competitive sport, and they told him you have VSD suddenly, and he was never diagnosed, he never suffered, so he's asking your input at 17.
No one has heard that before? No. Okay, see, that's a good example of how things, we can all miss things, but unusual that no one heard it, start there. But now, okay, it all depends on how large it is, if maybe we can ask, and what are this, there's no symptoms, I'm assuming, because he wanted to play, I'm feeling. I'm thinking the 17-year-old youngster is feeling healthy enough to play. But on the other hand, a VSD that hasn't been dealt with up to that age has only two outcomes, so to speak. One is not big enough to cause a problem, or if it was big enough, now probably has caused a very significant problem.
Okay. So it depends on how big it is.
Yeah.
الحقيقة برضو سؤالي اللي قبل ده لدكتور أوزونيان، معلش يعني بعتذر على إنه أحيانا بتبقى الإجابة طويلة فالترجمة هتاخد وقت شوية. إنه سؤالي الأولاني ليه إنه دايما الأطفال اللي هم بيزرقوا في سن مبكر وبنقدر نكتشف ده بدري، زي ما هو قال إنه يعني بعض الحاجات دي أحيانا كمان بتاخد لمدة يومين ثلاثة، وبالتالي بنحتاج نعمل سيرجريز أو عمليات جراحية في أسرع وقت للأطفال دي. كان معايا سؤال من شادي هنا بيسأل، بيقول إن هو عايش في ألمانيا، عنده 17 سنة، والحقيقة هو والده اللي بعت السؤال، بيسأل هل إنه ممكن عند سن 17 سنة يقدر يحتاج عملية؟ إجابة دكتور أوزونيان إنه على حسب يعني زي ما بقول السايز بتاع الثقب ده. لو الثقب كبير هيحتاج طبعا، لو الثقب صغير شوية بتبقى له طرق تانية في العلاج. ومهم جدا انه زي ما انا قلت شادي ان انت تتابع مع طبيب، ولكن على حسب الحجم بتاع ثقب القلب. So
no, he should just ask the cardiologist these questions, because again, it might be that it's not a big deal and that he
can I have a question here. Can those like the acyanotic one can practice sport at any point?
Yeah, it all depends on what it is, yes. To be able to practice sports, the lesion has to be non-hemodynamically significant. We actually have tables and guidelines we go through, but yeah.
Yeah. Does it affect their intellectual abilities sometimes on the long run?
Yes. Now, there is a big burden, actually. We can look at it this way. Some congenital heart disorders are actually found in children that have other genetic conditions, most notoriously Down syndrome. But there are many others, trisomy 13, trisomy 18, Noonan's. There are many, many, many syndromes that carry an association with sometimes very specific, other times not so, a congenital heart defect. So in those cases, the developmental, neuromental complications or associations will be based on the syndrome, plus if the congenital heart defect required surgery, will be also something to consider as far as most open heart surgeries, especially the complicated ones, they're lengthy, and you go on cardiac bypass, your blood circulates outside in a machine, and is very well known to trigger inflammation, things like that in the body that affects they affect the brain. So there are complications, sure, either by association with specific syndromes or based on the gravity of the complexity of the congenital heart disease, the kind of surgery you get, and also the blue ones. Right? Now, one blue one that everybody would know is tetralogy. That is, the circulation is correctable within the first 2 months, even 3 months. Our surgeons can do that in a very little baby.
And
so
it doesn't affect their intellectual.
Well, you're not blue anymore. At least the cyanosis part, the blue meaning we have less oxygen than normal, that is gone away. Then tetralogy surgery has to go very well, no complications, things like that. But other congenital heart defects were very complicated ones that required 3-step surgeries, maybe a topic for another day. That ones, you meaning the baby, the child is blue up until at least age 3 or 4. There is no way to make them have normal oxygenation up to the last surgery, third stage, around age 3, sometimes 4, 2.5. So you can imagine, you live your first 2.5 years of life with some.
So on the long run it has some effect.
Oh, definitely, yeah.
Okay. الحقيقة برضو من الأسئلة الكتيرة اللي بيسألها كل أب وكل أم الطفل عنده عيوب خلقية في القلب، هل ده هيأثر على ذكاء ابني، على طريقة تعلمه في المستقبل لو الكلام ده كان بيتعالج بعمليات جراحية زي ما قال دكتور أوزونيان؟ لو يعني الموضوع كان سيفير انف انه يقعدوا 2-3 في عمليات جراحيه في الاول، طبعا على اللونج ران هيأثر عليهم بشكل كبير جدا. ولكن الحاجات البسيطه اللي زي ما قلناها بتتعمل في سن مبكر عاده ما بتأثرش على استيعابهم او قدرتهم التعليميه بشكل كبير. I'm sure one of the most common questions you get from parents, what do I need to teach my kid about his condition? And when every single parent should start approaching their kids?
Well, that's a difficult one, yeah. Obviously, the child has to know, and has to know in a developmentally appropriate way, assuming can understand. That's
right.
Another. So our problem, and I'm guessing the problem would be, our problem here, even if we live in LA, I mean, you've been where I work and you know how it works, how the things are set up. Our patient population is not affluent, and the socioeconomics is whatever it is, education level. So despite us explaining in detail to the families, even the families' understanding of the kind of heart defect their children have, especially the complicated ones, it's lagging really behind, I have to admit. And that despite all efforts, you know, drawings, pictures, conferences is not mattering. So therefore, for the kids then, for the family to be explain anything to the kid, I think we are also lagging behind in that sector. I don't see my parents understanding exactly the complexity. So therefore, what we are left with is we are left with 12, 13, maybe older, 16-year-old boy or girl that now we can directly explain and hoping that we go through. But what we are noticing, same at the Los Angeles County USC, taking care of adults with congenital heart disease also. I have noticed, been doing that clinic for now 14, 15 years. What we notice is that our adults also that were born with congenital heart disease, now in their 20s, 30s, some 18, some 30, regardless, in that age range, we even have 40, 45-year-olds, either operated or unoperated. But imagine someone that has had 3 or 4 surgeries, and very few of them, I can count on one hand, cannot tell me what's wrong with their heart. So it's a major problem. We don't know who's failing. We take it upon us when we talk with our adult
But
colleagues.
sometimes parent education and perception has like a big role in it too.
It's a very big role. I believe that when your socioeconomics is, when you're poor, let's put it that way, in blunt words, when you're poor, you have so many other things
to take care of. That I understand that the heart of your child is so important, but I think what our parents are looking at is the doctor is taking care of it. The surgeon fixed it. The cardiologist is going to look at him. My son is going to be okay. So educating a family like that, the word education kind of is lost in my mind. So what we try to do, what I try to do is make them smile all the time and then try to explain again and again. But you have to almost go yourself, not to the kids, but to the parents' level. So okay. We have a phone call. Let's take a phone call. معنا بير على الهواء. تفضل. حضرتك على الهواء يا فندم. Hello.
Yes, hello.
Hi, Pierre.
Hey, how are you?
Good. How are you?
Doing all right.
What's your question?
Specifically, my son was he had open heart surgery, and we just wanted to know if we were going to have other children, specifically, would they be like, what is the rate of them having the same congenital heart defect that my first son had?
Okay. So your question is the possibility of the other children to have congenital heart defects?
Correct.
Okay. May I ask what the condition?
It's called pathology of PLS.
Okay. And how old is the kiddo now?
He's 2. He was actually born in Cairo, and then he was rushed to sick children in Toronto, and then he was put on ECMO, which is an emergency bypass.
Yeah.
And then after that, they put a stent. 3 months later, he did an emergency open heart, and then now we're just, he's recovered from open heart surgery, and so me and my wife have been talking to a lot of specialists trying to find out if it's even possible to have more children, and would we have to go through the same situation again?
Yeah, no, I can answer that easily. You can have more children. I mean, I don't want to joke now, but of course, you being able to have children has nothing to do with your son's heart condition. Children you can have. Obviously, your worry is the other next baby is going to have the congenital heart defect also. You have 2 ways of looking at this. Yes, the possibility is more than the average person. Now, you or your wife don't have congenital heart defect, right?
I don't think so, but...
Only the baby, yeah. You know, again, talking about the fact that 1 out of 100 might have a problem, average, if one sibling has a congenital heart defect, then it goes to 3-4%.
Okay. Pierre, if he's still with us on معنا, Pierre?
I'm still with you.
Okay, so usually, as Dr. Uzunyan said, the percentage is 1 to every 100,000.
1 to 100, yeah.
100,000. So
no, 1 out of 100 babies.
Babies,
100.
yeah.
Not,
so,
right.
Is you or your wife have any kind of congenital heart defects? Any of your in-laws?
No.
No.
Okay.
So
the
only the baby.
Yeah.
Then the next baby's chance will be
1%.
4 instead of 1%, like 4-ish.
Okay. So the percentage is about like 4%. That's what we say. For the next baby, if you don't have any cardiac history, still 1%.
Yeah.
Right. So
and if mom has it around 2-3,
none of them does.
That's, it tracks down statistically.
So between 1 to 3%, let's say.
Like if mom has it, is a little bit more than if dad has it, and then if a sibling has it, they're all well published numbers. But I think the safest way to go would be monitor the pregnancy.
Okay. So Pierre, زي ما دكتور أوزانيان بيقول, the best way to do it is monitor your pregnancy, go through all those testing, If you don't have any cardiac history, that means like 1% chances. If you have you or your wife any cardiac history, it's about 3 to 4%. بمكالمة بير, thank you so much. It was very informative. Time flies.
No, I know.
It was a pleasure and honor having you
Same
today.
here.
We learned a lot. Thank you so much. بشكر حضراتكم على حسن التفاعل والاستماع, ونشوفكم على خير وحلقة جديدة من وايت كوت السبت الجاي. استنونا.